With that, we're going to proceed. And I think let's kick it off. It's now 3 o'clock, so let's Torsten in. There's Torsten, he's just joined us. Hi, Torsten.
Hi, V.
Hi. So welcome everybody. Another Wednesday, another Philotimo webinar. Thank you so much for joining us today. Today we have a very interesting topic, and our guest speaker joining us this afternoon to chat to us about cancer and fertility is Dr. Chris Venter from the Vitalab Fertility Clinic in Sandton. And little intros for those that are going to be watching our webinar later on or on our YouTube channel. A little bit of introduction. I am EVY MICHALOPOULOS. I am the founder and the CEO of the Mahi Philotimo Cancer Project. And joining me today is our co-founder, John Kombinos. Thanks, John.
Good afternoon, everybody.
And as mentioned a little bit earlier, our guest speaker joining us today, Dr. Chris Venter. Thank you so much for taking the time out to do the session with us today. We really appreciate you guys. And as mentioned, we're going to be chatting about cancer and fertility, a very interesting topic, one that we would like to be able to create so much more awareness around because of the importance specifically relating to fertility and those patients that have just been diagnosed, that are perhaps not being made aware of the pros and cons prior to treatment. And this is what we're going to be discussing today. So I think, Dr. Chris Venter, a little bit of an intro from your side. And then as we go along, if I have made the screen available to share, if you'd like to share any presentations. But I think I'm going to hand over to you, Dr. Venter, to do a little intro, and then let's go through your presentation. If anybody has questions, please feel free to text us at the bottom of the chat messenger or raise your hands, and we'll go back to some Q&As after the presentation. Thank you, Dr. Venter. Over to you.
Thanks, Evie. Thanks for this opportunity. I'm just going to share a talk with you I gave last week on the Global Oncofertility Consortium's conference we had.
Okay.
What I basically want to remember that oncofertility in the US and those countries has been there from 2002, so it's been there for quite a while, and it's now been established as if every cancer patient that goes for chemotherapy or any other form of treatment, they need to have counseling regarding their fertility as well, how the treatment might affect their fertility. So they wanted to know where South Africa is in the scheme of things and how we, so 3 years ago, I've made contact with the Oncofertility Consortium, which was based in Chicago, but it is a global network where most of the countries have started to join up. It was just quite strange for me in 2017 when I joined, when we joined at Vitalab. There was no sort of fertility unit in Africa that was involved in oncofertility. So it was quite new, it was daunting, but again, it was a challenge. And first of all, we do accept that our patients needed the service and that we in South Africa need to catch up. So they just wanted to know as what we have done in the interim since making contact with them in creating a national sort of network in referring our patients for fertility preservation. So just what I did share with them is, first of all, just to give some background on South Africa, to look at just about South Africa, what our population is, 58 million people, 12 official languages, 9 provinces, just to give a sort of a scheme of what our country is all about. And then, like I said as well, 2017, we made a contact. 2018, we first on SASMO's national conference, we launched it with one of our overseas partners, Professor Michael Grainberg from France, which is Europe's fertility preservation specialist in oncofertility. He's the president there. And then again, slowly, we've been invited to these national conferences to start talking about oncofertility. And what we wanted to aim is to get the partners, our oncologists, our hematologists, and our breast cancer surgeons on board, and to just to start accepting the idea, and also just to remind them about just to look at the patient in a holistic sort of manner as well. One of the things we wanted to share with them was to say that this is the new technology that has been there. It's been created. So again, just to say that for egg preservation, it's only been there from 2010, but it has been a massive sort of improvement in fertility preservations. And that we now were able to either freeze the eggs or freeze the embryos or freeze ovarian tissue, and we also started to freeze testicular tissue as well. But we just wanted to share it with them as well. Me and Professor Dimitro was involved in a study which they looked at 9 developing countries or resource scarce countries to say what is the oncofertility programs within that country. So what was the barriers, and first of all, what was the opportunities? So again, I'm going to use this as the sort of a platform to say, but how did we approach launching or creating a national sort of referral network in South Africa? So the journal basically outlined it to say, but what was our services that we had available? What is our current data how many preservation procedures are we doing in the country? What was our multidisciplinary approach? How do we get our partners on board? And I think this is where Philotimo becomes very important, as what we have gone to try and increase the public's awareness and also the medical professional, their awareness as well in oncofertility. And I think the other big task of all of this was to say, how do we standardize our care? I am on the SASRIC board, which is our board that sort of overlook fertility care in South Africa. And we are in the process of reviewing our accreditation standards to make sure that when we offer something, we offer a premium product. So something that don't give false hope, it actually gives the patient a good chance of preserving fertility. So we need to look at how we would be able to standardize the fertilization, the procedures as well, and to make sure that we give a good service. And lastly, I think, which becomes also very important, is looking at how do we help the patients to fund this sort of expensive treatment as well. So just looking at the services, in South Africa, we have 19 SASRIC accredited units. This is all part of the society. They adhere to certain sort of guidelines and standards. I was in the process. Now there has been 6 other units under this 19 accredited units that joined the Oncofertility Network. And as you can see on the South African map there, these flags, and part of this was to try and cover all the sort of corners of South Africa as well. We are working on Bloemfontein currently just to get a sort of a center there that will just sort of buy in and then either refer to one of the bigger units to do the preservation in these units. Again, so the network is there, but how we sort of apply the network and make sure all our partners get on board and apply the same sort of guidelines within the Oncofertility Network. So just to say what is the services that is offered, and I do think that most of our fertility units are of world standard. We are doing embryo freezing, we are doing egg preservation, ovarian tissue cryopreservation. That within the last 2 years, we also realized that, listen, what do we do with our younger girls that has not entered puberty? And we had to start looking at them as well before they go for, especially the girls with the leukemias and the lymphomas, these types of cancers as well. So we have started slowly doing ovarian tissue cryopreservation, and then 2 cases of testicular tissue cryopreservation in our pre-pubertal boys. And then again, the last service is obviously the sperm freezing that we do for our male patients. So again, about our data, what is our data that we have available in South Africa? So just to say, we had a South African art registry called SARA that has now been replaced by a new registry called ANARA. So this is the Africa network of assisted reproductive units. This is for the whole of Africa, where most of the units can then sort of lock their data in. So the first data on oncofertility preservation has been from 2018 that we started to update this procedures. Unfortunately, it's just been for egg preservation and for ovarian tissue cryopreservation. So as we have started to push to say we need more data, the new updated software from 2021 will involve all the fertility preservation procedures as well. So again, it is very important for us to track ourselves, to see how good are we doing and how are we progressing on increasing this numbers of procedures. Again, we've got an excellent South African cancer registry as well. So what I've done, I just compared the 2 sort of data sets of 2018 to more or less to see where are we. And this is looking at the 2018 data. So according to the South African Cancer Registry, if you look at women of reproductive age, and we just took the 12 to 40-year-old patients, and we look at the most common cancers that we were able to see, we got to about 5,278 recorded cases of these most commonest cancers in South Africa under our female population. Again, if we look at what was recorded in the ANARA registry on how many fertility preservation procedures has been performed throughout that year, it was 54. So if you do make the maths, then you can see that less than 1% of all cancer patients within the reproductive age is receiving fertility preservation techniques. So again, I think that's our target group, to say we can only grow on this number. And I think we've got our target to set out to say, let's start tackling this issue. So, and building on getting just past the 1% at least. Again, what we have done in our unit here in Johannesburg at Vitalab, I've asked one of our PhD students just to look at what is our data from 2015. And again, just looking at the data there as well to see how many patients, unfortunately it's now blocked now, I can't see, but how many patients we have done fertility preservation techniques on, how many of those patients that we had to use their eggs. 6 of those patients have conceived by just within a 5-year period. I think that's excellent. So where these patients, either the egg or embryos has been preserved, and within a 5-year period, we then said, well, let's start using these eggs or embryos. We transferred it, and we had 6 pregnancies from these procedures. And then 3 of these patients that conceived naturally as well. And I think that's also important to know that if the patients do not opt for fertility preservation, there's still a chance of them to conceive naturally. And we see fertility preservation as a sort of a insurance that you do take to safeguard some of your eggs, but you know there might still be some eggs left that you can actually sort of conceive with as well. Just to look at the data as well, and I think this is quite encouraging from 2017 when we started joining the consortium, and to actively try and improve on getting the message out there as well, how we have grown up until a year like last year with the COVID pandemic. That was our best year of doing fertility preservation procedures as well. Just another thing, we saw 25 patients within that year, and this is the different sort of cancers that they were sort of dealing with. After 25 patients, we saw 15 of them opted for fertility preservation. And that is also important because we know that most women would like to do it. If we offer, doctor, I'll rather do it, but then why is there 10 of these patients that did drop out? And the only reason for that was actual cost, where they say, I can't fund this out of pocket. We don't have the finances. We already a bit strained with the cancer treatment as well. And I'll come back later to this sort of funding, how we have improved in this as well. So, and what is quite exciting on that sort of that field as well. Just again in 2021, and again with the support of great doctors, people really, oncologists that's very passionate about fertility preservation, we have seen a massive increase in the patients that presenting to us as well. Getting the message out there and to say we want to do it. We are still dealing with the challenge of funding, but I'll come back to that sort of challenge just now. Again, looking at our male patients, and as you can see how this graph has grown from 14 patients in 2020 that presented for fertility preservation, and 13 of them said we would like to do it, and they did do it. So only 1 patient dropped out. I don't know exactly what the reason there was, but again, I think the big factor here is the ease of obviously giving us sperm. That's the one. And the other thing is the cost. The cost is quite low for preserving sperm. It's in the order of about 4,000 Rand. And that includes the first sort of year of cryopreservation as well. So again, I think one of the main sort of targets or things we need to concentrate on is how do we improve funding for these patients. So, but this is our data, and we're quite exciting to share it with you as well. Again, looking at the multidisciplinary approach, and this is specifically talking to the oncologist. 2020, we've been invited to quite a number of talks, conferences. Again, due to the COVID, none of this has taken place again. But again, this is just a very good sort of buy-in from our oncologist partners as well, and to see their endorsement to say, yes, we are more than welcome to come and share what we can offer their patients. So this was, but hopefully once COVID is passed, we will be able to share these platforms with them in future during their national conferences. Again, creating awareness, and I think this is where Folletimo becomes so important. Your name, without you, I didn't ask for your permission, but I did use your sort of your icon during this presentation to the overseas guys, well, to the world actually. But then again, just Oncology Buddies, excellent articles that we've been publishing last year, very good stories that were told, success stories, stories that gives hope. That were told in Onco Buddies, sort of on a sort of 3-monthly basis. Our partners in cancer, our Folletimo partners, and again, part of the Folletimo, and we still need to talk about this, but central to this whole network of fertility preservation is our Oncology Navigators, and I see them as the sort of the glue that sort of put all these disciplines together, that sort of orchestrate this whole sort of process. So as part of the Oncology Navigators is we got the ECO, which is a course that Oncology Navigators can do. It's an American-based course. They can only allow for 13% of the participants within that course to be from overseas countries, and they've allowed 3 of our Oncology Navigators to partake within this sort of this online course, which is an excellent course, and just helping patients or navigators to assist them in to create a oncofertility sort of navigation sort of way. So we're quite excited. I think once these 3 Oncology Navigators are going to be qualified, we would want to roll out this ECO sort of course in South Africa to say let's share the knowledge amongst our navigators. Again, lastly, standardization of care. I'll just quickly touch up on this as well, but SASRIC, our society, our fertility society, I'm part of this group that is now overseeing, and I said to them as well, the oncofertility sort of section is the one that I would like to take care of, because we can improve our fertility care, but once we know our fertility patients, hopefully they get pregnant within their first sort of cycle of being fertility procedures. But if they don't, then they can do it again. Again, comparing that to our oncology patients, they only have one chance to get this right. So we need to be very stringent when we put down the guidelines to say what is good enough, and obviously always pushing for better. But then again, this is looking at the way we stimulate our patients, the way that when you see a patient or a patient is referred, she does not get on a waiting list. She must be seen within 48 hours of being referred. We need to start the stimulation or the fertility preservation procedure as soon as we can. I think one of the promises we made oncologists to say we will only take up 10 to 12 days of their time prior to starting chemotherapy to make sure that we don't waste time before they can get to effective sort of chemotherapeutic treatment. Again, so this is all part of the standardization of care. There is a ASRM, American Society of Reproductive Medicine, online course, which encourage our doctors to do and to get them qualified as well on the newer techniques of fertility preservation as well. And again, lastly, I want to come to the cost part, the funding part, which is always, it seems to be not just here in the US, all over, not all over, so I mustn't say that, but in the US, it's also sometimes challenging. But as we can see that most of these sort of states of them, most of them is now starting to accept oncofertility care as a standard of treatment, and they need to fund for that as well. So it does not need to come from the patient. Just say something like a country like France. France, it's also mandatory now as well. It's in their sort of national guidelines, which is now law, that all patients within their reproductive age needs to go and see a fertility specialist prior to starting their fertility treatment as well. And this goes the same for New Zealand. It goes the same for Australia as well. So I think they have progressed, but also realizing we're not in one of these countries as well. We have other challenges that we also need to meet as well. So having said that as well, that one thing we've seen as well, we as private units have also sort of as well to say, let's start a public-private partnership here and to say we can assist these patients with this is expensive technology, first of all, and it's expensive running a world-class sort of fertility unit as well. And not to reinvent the wheel, let's rather have the services available to them as well, and to build on sort of that platform. Having said that, I think the most exciting news within this year, and I think by the end of this month, we're having final talks with one of the major healthcare funders in South Africa. And they have taken up the task to say, within this year, we will get all the guidelines and we will set out the rules. And then from 2021, they will start funding for fertility preservation. So I think that's been a massive achievement. And I do think this sort of leading healthcare funder, I think most likely will inspire the other medical aids as well to say we would also like to get on board of these success stories. And I think just Oncofertility, if you see the people you deal with, again, talking about the partners of Phillippe itself, these are people that selfless, they want to see the bigger picture and to help patients that really is more in need than any other, I think, sort of medical condition. So just importantly, the healthcare funder did say that they wanted two things from us. The one was a good accreditation process, which we say we have. And the other thing was to have accurate data as well, and which we also had as well. It's not complete, but we're working on getting it more complete as well. So that was quite crucial in the negotiations. Another development was a trade company, one of Ferring. It's one of the big pharma companies in South Africa that supplies drugs for fertility treatment, has come on board, and they are busy creating a fund where most of the pharma companies will buy in and sort of would assist in funding as well, that we have one of these sort of trust funds that can assist patients that need fertility treatment or that just at least just need some assistance, in which form as well. So even if they can just assist with the smallest amount of, they are looking into this as well. And I think going forward as well, we still need to have EVY, we still need to talk as well at how we can assist in sort of helping this pharma company, which wants to be seen as impartial, but also would want to see how we go about in assisting them to identify people that is in need for fertility preservation and in need for funding. Again, just in conclusion, all of this is a collaboration between NGOs like Phillippe, between medical aids, between oncologists, hematologists, reproductives. It's just all a network and a collaboration. So we always see our oncologists, we always see them as the primary caregivers. So we can't go ahead and do fertility preservation if they have not okayed their patient to come here as well. So they are the gatekeepers, but then again, they are very amenable gatekeepers. We've just been seeing a lot of referrals from them as well. We will always keep on working on a quality product and always try and improve on our technology just to try and to have a better preservation of these of the eggs or the sperm or the tissue. And it is a continuous commitment as well. So I just shared this last slide, and again, I all think, and you as well, you always leave footprint in people's life, and I think this is what we want. We want to do good for people, and we want to leave a mark there as well. So I thank you for your assistance. I thank you for your platform, and I hope we can in future just grow together. I concluded the presentation to the global partnership to say that I think prior to 2017, before you can run, you need to learn to walk. I think we're busy walking, and I trust within 2 years' time we will be running a very successful sort of oncofertility network in South Africa. I thank you, Evie.
Thank you, Dr. Venter. That was very interesting and very informative and very exciting at the same time, especially with the partnerships and the multidisciplinary groups and most importantly, the funding side, I think, which is always the big worry that most cancer patients face, as we mentioned earlier, when they are going through this journey, because of the fact that not all of the cancer patients are able to get their treatments covered by medical aid. Some of them do, some of them have half payments, co-payments, they don't have gap cover. So it is a financial huge pressure of knowing that there's some light at the end of the tunnel, I would imagine, for something that is really so important in terms of their fertility and preserving that as such for a later stage once they've gone through the journey of the treatment, to then be able to have that weight lifted off your shoulder, that the next phase of their journey, which is phase, I would say phase 2, is then to be able to move into that phase smoothly, knowing that the measures have been put down, the facilities are available to them, and the funding has been taken care of. So that is our message that we're going to try and get, John, and I think you'll agree, is get that across to as much people as we can, because it is a very important step in their journey, I think.
Chris, absolutely, and very interesting. You've touched on quite a lot of aspects of this process that Philotimo are involved in, and I'm sure Nicole's ears pricked up a little bit there when we were talking about oncology and navigation. That for us is very close to our heart, and through the journeys that we've experienced, we've seen how important that is. So very, very, very excited to be a part of that. Chris, can we, just for the purposes of those listeners and viewers that are going to be watching this at a later stage, can we dial into basics and talk about how one would identify this particular need and the process to approach Vitalab in order to ensure that they are protected going forward?
Yeah, so John, at this stage, it's so we've got a 24/7 number. So we always said we will have an emergency number for this as well. I'll ask Alyssa just to share that number as well at a later stage. That you can just maybe share it as an attachment. But at the end of the day, this is about a Friday afternoon call from an oncologist to say, or a WhatsApp. So we give our numbers as well as on WhatsApp, and just a rapid response. So I think that's the most important part, is just a rapid response to say, where do I go to as well? John, something else I just wanted to also to say as well, and some of the patients we've seen as well, let's just say, the other day I saw a patient who's 44. She just met Mr. Wright 6 months ago. She's now been diagnosed with breast cancer. So again, I saw that patient to say, well, fertility is not there where it needs to be, but again, just giving her the alternatives to this as well. And we did not do anything for her except for giving her guidance to say, once this is over, once this is fought, and it's won, then to come back, and there's always something like egg donation. And I think that is also important, that we cannot help all the patients, but we can at least give them good counseling regarding, and I think once they sort of feel empowered by, they sort of take an active role in preserving their fertility, or at least just know where their fertility currently is, to say as well, okay, and these are the alternatives as well. So I think it's not just always doing the procedure, but it's also about the counseling as well. So John, regarding the networking, the numbers, that I will be happy to share, and I'll ask Alyssa just to share that, because I do think that, again, like oncologists sit with a patient on a Friday afternoon, everyone is gone. So who do you phone now? It's your WhatsApp, and we will get hold of that patient over that weekend. So and to say let's. So I've just think to break those barriers of communications and to improve on that as well. I think Nicole, yes, I would like to see her here. Nicole, I owe you. Well, you owe me a visit, but I owe you a time. To say when you come, because I do see your role. There's lots to be done here. So yes.
Yeah, thanks, Chris. Can I just ask you a question when you talk about the private-public collaboration or partnership? Because I work with Prof Ben at the breast care clinic at Helen Joseph, and I mean our patients, the state patients, it doesn't even come into the conversation. Fertility treatment for them. I don't know if, and I highly doubt that Charlotte McKeke have counselors that counsel them before they start chemotherapy. So how do you, for those kind of patients, it's actually quite sad that, they don't even have an option. How do you propose working with public-private?
Yeah, so just on the bits, sort of, we had at some stage we were consultants there, but there has been a few changes in the management. So we associated now with, I'm an associate lecturer at University of the Free State. So that partnership has been built there as well. What I do know is that they've asked us this year to also, again, relook our involvement here at WITS as well. But just to roll it out with them as well, to say we're happy to share the knowledge and to share the expertise in this as well. This is not about an ego trip. This is about helping. But it's still, like I say, it's before we roll it out, before we offer it. And again, this is one of the frustrating things, to know that this certain medical aid will pay for fertility preservation next year, but how does it help my patient that I'm seeing today? Not much. But again, just aligning that sort of partnership to say, okay, guys, listen, we need to sort of share the knowledge and share our techniques as well. So I think quite good development with WITS as well this year, to start with the fertility sort of unit, and then as part of that, it is a sort of sub-arm, is the fertility preservation part as well. And unfortunately, if fertility, we've been growing in this year for in this country for very long now, and I think we're right up there now to say this is the techniques. It's been well developed, it's been well established. Now let's just start implementing it. And I think they're not reinventing the wheel at WITS to say just copy and paste what we have done. And again, everything is there, so we're happy to share. So, but you raise a good point, and I think this is for a conversation that we can pick up. I know Carol's going to pick it up at some stage.
Yes, no, I'm sure she will. But also, it's all the funding thing. I mean, we have a breast health policy that's been approved, and I mean, it's never been implemented. And I think there's a lot of cancer policies that have been approved, but I mean, they're approved by the national health budget, and then the provincial health departments don't have the money to implement. So we've got all the fancy, guidelines on what we should do. And I mean, as we know, with just normal treatment, the cost, I mean, at Charlotte at the moment, I mean, radiation is a 5-year waiting backlog for prostate cancer treatment. So I mean, as it does all come down to funding. And I mean, I know Carol's very pro trying to work towards public-private partnerships to try and, but it is like a bit of a knocking your head on the wall with the whole government.
Yeah, but I think, it's just to keep on pushing it. So again, so one of my colleagues, so we built on and again, this is now an African Oncofertility Consortium. This is part of the AFFS, the African Fertility Federation Society. So again, another society, but again, this is where we try to see what was oncofertility like in Africa. So again, South Africa, I think we're busy getting the system rolling. Tunisia, they've been doing this, they're well ahead of I think some other countries. And again, it took 1 or 2 persons to do it there. And again, the other country was Egypt. So it's just always just good to see these countries and say, okay, this is where we start. And then how do we roll it out? But then again, you realize a country like Mozambique or Botswana, not so much, but Angola and what's the other one?
Malawi.
Yeah, we'll don't even talk about Malawi, but just these countries as well, they are struggling still to get to fertility care. And not even just oncofertility. But again, you have to start somewhere. And I do think that the ripple effect will, even if it's slow, I do think that if we can just see how the fertility units is slowly starting to come up in these countries as well, I think this is just to try and push the boundaries there as well. But part of fertility care is oncofertility. It's not like seen as a separate sort of subject. It's part of that. So, and again, I think that's the exciting thing as well, where Africa can. And if you saw it 2017, where we planted the first pin drop of the consortium in South Africa, then it's Nigeria, then Tunisia, and now there's six units here. It's just amazing to see. So it is a ripple effect, and I do think it's encouraging to see. So, but yeah, we'll keep on pushing. That's it. But yeah, you need to come and visit the site. So.
No, I'd love to come. Yeah, I'm doing an American, well, I have done the American Oncology Navigation program. So it'd be quite interesting. I'd like to compare your ECHO to the AONN, which is a national American organization. Excellent. It would be interesting. Yeah.
But just on Oncofertility Navigation, we've on Rowan, I don't know if you know Rowan Atkinson, so we had some talks with them as well. And part of the plan was to reignite, you can call it that, a network of navigators. So this year, and I've actually asked one of the pharma companies to assist them to set it up, just to get a sort of a special interest group to say, well, okay, now we share our interests, we see ourselves as a unit, and so that process is busy happening, and that people are talking amongst each other as well. So that's also quite exciting, because I do see you as the central role in all of this.
Thank you.
Doctors is not good in admin, so they just run around.
Thank you for that. Can I ask, is there anybody that would like to ask Dr. Chris Venter a question while we're doing some Q&As at the moment? Let's just see if anybody has a question. No? No? I have some questions that have come through, Dr. Venter, so I'm just going to read through a couple of them, and then maybe you can just answer them as we go along. So obviously cancer treatments can affect fertility. Just a brief thought on why it affects fertility for those that obviously might be listening and are bamboozled with all the cancer terminology and coming to terms with what's been happening. So why does it affect fertility as such, and which chemo treatments specifically cause the most?
Very, very good question. I don't have that slide currently with me now, but again, when we look at, we know one thing is that chemotherapeutic drugs or even radiation therapy does affect the young active cells, which is cancer cells. But part of this young active cells is also your young eggs, your oogonia, your primary follicles. So, and these eggs, unfortunately, is as susceptible to cancer treatment as your cancer cells itself. So they are basically collateral damage. I think Teresa Woodruff the other day sort of described it so well to say, as sort of your hair follicles has been sort of, you are losing your hair follicles, you are losing your follicles in your ovaries as well. So I just think that is a sort of a good analogy to have. But yeah, so eggs, fertility, the eggs is collateral damage. Again, just to know that women in their lifetime will have more or less about 300,000 eggs. So from the age of 12, when you start to ovulate, gradually you lose about 10 to 12 eggs each month. And as you do get older, then obviously your reserve starts dropping. And as the reserve starts dropping, the quality of your eggs also starts dropping as well. And this is why women, when they do get older, they do take longer to conceive, and they are also at high risk of an abnormal pregnancy as well. So this is all due to the egg reserve. So as the egg reserve goes down, then the abnormalities increases, and the chances to conceive also gets less because the quality of the eggs decreases. Again, we don't always know what is the rate of the loss, but just if you look at your certain types of chemotherapeutic drugs, let's say your alkylating agents, your sort of your taxanes, those are, most of them is used during breast cancer. These are the most damaging to your egg reserve. And just to use a sort of a comparison as well. So we say one sort of chemotherapeutic dose can accelerate your fertility age by 1 to 3 years. So again, if you get 6 sort of courses of chemotherapy, 6 times 3 is 18. So if you're a 20-year-old patient gets this sort of, let's say, alkylating agents, it can advance you to a 38-year-old woman's sort of egg reserve. And that is just sort of, say, worst case scenario, but this is what can happen. So again, it's about then safeguarding that as well. So to say that trying to stop this rapid loss of eggs, to say, let's safeguard some eggs out of the sort of firing line.
Yeah.
So yeah, but yeah, you're right. There's different types of chemotherapy. So when I see a patient, then we want to first establish where is the current fertility, where is the current egg reserve. I think that's very important when Nicole sees a patient, or if there's one test to do, and that's your anti-Mullerian hormone. So this is actually, I tell the patient, this is your fertility counter. That's one test to tell you what is your current egg reserve. And then to do that test, and then always after chemotherapy a year later, then to say, okay, repeat that test. And I think that's your most valuable marker to see what's the effect has been on your egg reserve. Yeah. Again, there will be eggs left. It's not to say you cannot fall pregnant, you can, but the chances are lower, and it can sometimes take longer. So, and as long as patients do know this as well. So first to try and establish where's the fertility age, and then try and see what chemotherapeutic drugs she's going to use, because that will sort of give you an indication of what will the effect be on a fertility score. And we always say she's either at high risk, at intermediate risk, or at low risk, and again, to help her there as well. So
thank you. And Chris,
Professor, can I just ask? Sorry,
no,
Evie, I just want to ask. That they recommend, or Carol recommends, that a patient shouldn't try and fall pregnant for at least 2 years after chemotherapy.
Yeah, so usually the damaging cause, when you do know what the chemotherapeutic drugs does, it sort of breaks the DNA strands. It causes abnormalities in these eggs. And again, the young eggs that's still there in the reserve deep down as sort of germ cells, they will not be affected, but it's the eggs that sort of more going to the developmental phase that is at risk. So usually we would say within a year not to conceive, because that sort of effect on the DNA of the eggs can last up until a year. And then depending on what the oncologists would say, well, is she happy for her to continue with anti-hormonal treatment, or can she conceive? So we would take a year. And I think that's the national, or the world, the guidelines as well, to say not within a year. So I do ask, Nicole, all my patients to come back after a year to say, okay, this has been the effect on your reserve. Give them a bit of counseling on their ovulatory cycles, how they ovulate, has it returned, and then to say, happy, if your oncologist is happy to conceive, we're also happy as well. But like as well, and this is also important, that some of them need to go on anti-hormonal treatment for 5 years. And again, when someone is 35, she gets a chemotherapy having an effect on the egg reserve, and then have to wait another 5 years before she conceives. Those are the group that you would just say, no, you need to have, because again, there you have also time as well. They can't use the eggs, and there is the age-related effect that you will have on the quality of the eggs as well. So I think that's very important. And fortunately, some oncologists would want to feel it's safe to have a bit of a fertility break, as we call it. And last month, we had 2 patients that we transferred embryos we had stored for them. So they were still down-regulated. We just give them estrogen for 12 days, 5 days progesterone, and then transferred the embryos. And yeah, fortunately, both of them has conceived. So yeah, it does sort of speed up that process as well. If you have something in the bank to say, let's get you quickly to a pregnancy as well. So, and you don't take years to conceive, and obviously get exposed to the estrogen sort of component as well.
Yeah, thank you. Chris, you were spoken about how it affects the ladies, and a question that I have is, obviously, can cancer make a man infertile? And cancer treatment, how does it affect fertility in males?
No, very good. So for males, it's slightly different than females in the sense that they have obviously spermatogonia, which is germ cells, and germ cells in men keeps on producing sperm. So let's just forget about cancer now. They just will keep on producing sperm. Obviously, after the age of 50, we know there is a slight decrease in sperm concentration, in sperm, the way the sperm is looking, and their motility as well, getting a bit older. But again, men can make babies up until the age of 80 plus, UEFNA, those examples. I don't know, but so again, so the effect of then chemotherapy in men is slightly less. We know this as well. But then again, in fertility preservation in men, it's much easier collecting the sperm. It's usually one ejaculation. Some of us will tell them to come for another ejaculation. We can be done back to back, one day after another. And once we have fought or frozen about 12 straws, which is usually one ejaculate, their fertility is preserved. They can go ahead. Again, similar to the alkylating agents, to radiation. Radiation on testes, which I've been told doesn't happen much more, but is very, very detrimental to sperm as well. Again, the same principles will apply. Within a year after chemotherapy, they can then come back for another semen analysis, and then try and conceive again. So the chemotherapeutic drugs would have worn off on the DNA damage to the sperm as well. But yeah, so equally going to, again, the younger the age, the better chance of these men to recover. Okay, this is also important. And the type of chemotherapeutic drug that was used will also determine what the effect would be as well. So I think for males, and I think this is so important, that if you look at the American data, they would say that only in 50% of males prior to going for chemotherapy that were still having wanted to father a child, only in 50% of them fertility preservation was offered. And after 50%, only half of them went for that option as well. I do think in South Africa it's different. I think every male that was sent to our unit, not everyone, but the majority of them will preserve their sperm. And like I say, it is an easy process, and you store it, and if you're going to use it one day or not, it's there. So and you store enough to make sure you will complete your family. So so I do think the message, when this is what I actually want to say, is we need to get the message out there to the urologists as well. I know I haven't been focusing much on them as well, but there's just so many things to do and place people to see. So so yeah, I think it is important then to get a urologist on board as well.
Yeah. Thank you, Chris. And we've been chatting a little bit about people with certain types of cancer, or who are getting cancer treatment or treatment for cancer may have fertility problems. Taking into account, you mentioned briefly earlier in your presentation, children and teenagers who have cancer and are often of special concern. So whilst we're on the topic now of children and teenagers, does childhood cancer affect fertility? And if so, how and what is the best advice that we can give parents out there? Because, you know, I'm sure it's hard enough to deal with the fact that your child has been diagnosed with certain cancer. And I think the last thing on most parents' mind at the time is you know, taking into consideration what their fertility would be like in 20 or 30 years time, depending on the age. But I think it's important, as you mentioned earlier, that as you mentioned, the leukemias and the, you know, those type of cancers that are affecting the children. And I mean, we see from the stats that there's about 800 to 1,000 children diagnosed yearly in South Africa. And these are all childhood cancers. So some advice or your thoughts on this?
Yeah, so this question was actually asked by one of the so the Philadelphia Children's Hospital in the States. I think they've got the biggest sort of children's program for oncofertility, and they actually asked me, but what is happening in South Africa to your children? And so I just said, I'm ashamed to say it as well, but we've been focusing on adults because it's an easier sort of topic to address, the adult, which is slightly more mature. When you move to the children, we know all the multifaceted sort of emotional burden we're dealing with as well. But yeah, so again, we need to work on that as well. So we focused on the adults, I think within the last 2 or 3 years, fortunately. And again, this is just to say how amazing people is working out there on the oncologists, the pediatric oncologists. They've contacted me with 2 young boys, and again, quite shortly after each other, that they knew these boys were going to get chemoablative or stem cell ablative sort of chemotherapy, meaning all their sperm will be sort of ablated. There will be nothing left. The germ cells will be depleted in the testicular tissue. So realizing that they are causing infertility, at the end of the day, saving the patient's life, but then again, looking a bit broader. And I think being mothers themselves, I think they realize just what massive impact that actually is on not being able to sort of transmit or have your biological child one day as well. So yeah, I was then forced to make the step to say, not forced, but just asked to make the big leap to say, let's look at fertility preservation in childhood cancers as well. And yeah, and I think that steps has prompted us to speak with the world leaders in doing that. And we've been doing it now for the last year or so, but making sure again that the technology you apply, this is technology that has been still seen as experimental, but a year, to 2 years ago in the US, in the States, and now being sort of lifted. It's not experimental anymore. We're now getting pregnancies from that stored ovarian tissue and testicular tissue as well. So again, as this, there has been a progression in sort of the research, now it becomes, they lifted it us as well. So while they were for the last 14 years trying to get it worked on it, trying to improve on the technology, we now just jumping on a bandwagon, making sure we comply to the rules, and now we say we will be able to offer it. But again, we don't want to just say, whoops, it's there. We want to get our houses in order to know this is the rules of the game, and this is how you validate something and how you make sure that what you're saving is actually worth something. So
yeah,
I do think, and I think in future that the focus for surely will be shifted to the childhood cancers. And for now, we helping on an ad hoc basis, but we haven't sort of rolled out a campaign on it.
So I think that, Dr. Venter, that's an important subject, and one of the reasons why we as Philotimo Cancer Project have launched a new addition to our project, which is the Philotimo Kids Club and Kids Program. And we're going to be focusing, and we'll obviously have more greater conversations in depth about this, but I'm thinking our partnership with Vitalab, especially with the Philotimo Kids program, will bring a lot more benefits whilst we now start to educate the younger youth of these options, the processes, the journeys, the pros, the cons, from a very early stage, so that we can now be able to share that information, and we can obviously collaborate and start sharing a lot more detailed fact sheets about why it's important for the parents to take this into consideration and speak to their oncologists or their children's oncologists about it, as you mentioned, because it's not only just the win of getting past the cancer treatment, but it's also to be able to, as we said, get to the next level of their stages in life.
No, certain, and we know oncofertility, fertility preservation gives hope. There's lots of publication on that as well, and again, it's just the other day I had a young girl here, so we vitrified 8 eggs for her, but just so nice to see her looking at those eggs. So,
yeah,
it's just nice. You just saw her lighting up. So, and I think it's good. It gives them something for the future to look forward to. My 8 eggs is somewhere, and that will be my future. So it's noble work. So
thank you, Dr. Chris. And then I just got a couple of questions on the process. So we've spoken about why you should freeze the eggs before chemo. One of the questions we had is egg collection painful? Is it painful? And is 40-year-olds too old to freeze eggs? I think we've briefly chatted about the 40 sort of age.
Yeah, with this healthcare fund, and they want to look at what is the guideline. So what is the realm and what is the age group we're looking at as well? So we 40, but I still need to look at what is France and the US doing as well. But we know that the older you get, we will certainly not go past 42, because we know that there's almost 100% abnormal rate in those eggs as well. So why do you freeze then? Because you only find out what you're frozen once you fertilize it, which might be years later. So what have you achieved? And I think that's achievement of false hope, which we never want to do. But yeah, in a 40-year-old patient, if they've got a good egg reserve, then we freeze. Even if they don't, you at least just freeze what you have. And at least, like I say, empower that patient who said she did something, okay? So we always say we freeze her potential. We don't know what the potential is at that stage, but at least you freeze it. So that is on fertility preservation. Is the pickup, is the OPU, so it's been called OPU, oocyte pickup, or sometimes we say harvesting, which sounds more like a farmer, but harvesting it's also, so that is a 10-minute procedure under conscious sedation. So we have in-house sedationist, put up a small drip, injection transvaginally, like we do a transvaginal ultrasound scan, like for a normal routine gynecological examination. And through the vaginal skin, we then just retrieve these eggs as well, which, like I said, is a 10-minute procedure. It's not painful because it's the patient is fully sedated afterwards. Maybe a bit of cramping, but nothing more than a period pain. So yes, this is the way the patients will describe it.
And Dr. Venter, one last question I have is, or two actually, but let's go with this one. A question that came through was, can cancer be passed from mother to fetus?
Okay, it's a good question. So yeah, so the question is that eggs or embryo affected by the cancer? The answer to that is no, it's not. There is obviously a genetic sort of link. Sort of what is that embryo's genetic link? So again, looking at, maybe we'll talk about that as well, the BRCA1 and 2 gene mutations as well. So one thing we know, that if a patient do have a BRCA gene mutation, so those embryos prior to transferring them can be screened for that gene mutation. So I think that's also very important. We've had it before where the patient has a very strong history of breast cancer. She's been positive BRCA1 and 2 gene mutation. So as we can test these embryos for Down syndrome, we can also test them for the presence of a gene mutation as well. And obviously, those are the embryos we don't always would like to transfer first. So yeah, it gives that at least that patient the knowledge that her offspring, a daughter, will not be suffering from the BRCA1 and 2 gene mutations as well. But cancer in itself cannot affect a embryo genetically. So, but obviously there is the background genetic risk that's in a family that we cannot at this stage exclude, except for the BRCA1 and 2 gene mutations.
Yes. And the last question I have was, can you have a baby if you have leukemia, or if you've had leukemia? Or...
Yeah, so again, if a patient has been in full remission and she survived that, yes, certainly you can. I think that the leukemia difficulty comes, there's one, so if you have a young patient, obviously hasn't entered puberty, you can have to freeze ovarian tissue or testicular tissue. The question is, this is a blood-borne cancer, so obviously it can be in the ovarian tissue as well. And I think the challenge comes in transferring that tissue back into someone that is now ready to start with their family, and potentially transferring tissue that might still have lymphoblastic cells in it. There is ways of determining how we, I'm not going to go into that as well, but this is where the development goes. There has been now 2 cases recorded in Israel, Dror Meirov's group, that on transferring a patient who had leukemia, transferring the ovarian tissue back into, and she conceived. So again, but it's always about, do you transfer tissue that might be affected? And the most research now is going into try and identify, is there some of these lymphoblastic cells still within this tissue as well? So what we do is, once we freeze this tissue, we have the histopathologist do some staining and see if he can pick it up, and he will. But we know this is not good enough. We need to do more. We can look at a gene angle or do xenografting as well. But yeah, I think those will be dealt with once we. And again, if you freeze ovarian tissue now in a prepubertal girl, most likely in 12 years from now, we will be able to use it. And again, the rate the development is going now in this field is amazing. So they now start talking, the Teresa Woodruff's group from Chicago, talking about the bioprosthetic ovary. I don't know if you heard that term before, but this is where they grow a 3D sort of ovary, and with matrix as well, and then where they start to put back some of the stem cells back into these ovaries, and that these ovaries might one day be functioning as a prosthetic ovary. So,
Wow.
so that's, yeah, it's amazing to look at where the people have gone. And again, we're catching up now, but it's just good to catch up because they've done most of the work. So
yeah, for sure. Thank you. So before we close off, just last round, if anybody has any questions to ask Dr. Chris Venter before we end off the session, let's just have a look.
Just a comment.
Hi, I have a question.
Yes, we've got 2, so go ahead, Drika.
Is there a maximum time limit in which the eggs can be stored or not?
Good question. So the data, the technology, the rapid vitrification, which is where we freeze an egg in a crystal-like state at minus almost 200 degrees Celsius. So that technology has been available in 2010. Okay, so we have good literature now and good pregnancies coming from eggs that has been vitrified for 10 years plus. So, but obviously it's ongoing. So for now, we'll just answer that as at 10 years. Yes.
Sure.
Okay, thank you.
Steve, you had a question?
Yeah, I just wanted to say I think this is very exciting technology, and well done on getting, I think it's Discovery on board. I read something about that.
All right.
Don't traditionally pay for fertility treatment. So that's great. And also, it seems to me that it's becoming more and more relevant because we are seeing a lot, if you take breast cancer, for example, a lot of young women coming through with breast cancer. Whereas in the past, you used to assume age 40 plus, we're seeing a lot of younger women coming through that are obviously of more reproductive age with these types of cancers.
Yeah, certainly, Steve. Yeah, it was 2 weeks ago. I think I saw 5 within. I think Prof Ben is keeping me very busy, but I've seen 5 ladies within that week, and this is, yeah, and again, you mentioned the name Discovery now, but I did give them an emergency call then. I said, listen, we need to make this earlier because I can't deal with this anymore. Yeah. But yeah, we're having final talks with them later this month. Last year we saw them and then they agreed to fertility treatment then, but only for the top plans. For oncology preservation, we're going to push for all the plans. So we can't have just the top plans covering fertility preservation for cancer patients. Yeah. So, but I must say again, 2 really nice ladies that understands, I think it's the maternal side of them that understands the importance of all of this. So, so we're very fortunate to have them on board as well and sort of looking into this as well. Yeah, but I also experienced the young patients that's presenting, Steve. So
yeah, sure. Yeah. Any other questions? No? Right. So we've reached the end, and I think we've gone a little bit over. So I'm sorry about that, Dr. Venter. I know you're busy, but a very, very informative session. I think so much to build on, so much to work together on. Before we end off, I think I'd also like to thank our partners from BMW Bryanston, who have sponsored this webinar for us today. So a huge thank you to them and Stavros and his team from BMW Bryanston. And of course to Vitalab for taking the time out today to share some education and information on the importance of cancer and fertility. So Dr. Venter, to you and your fantastic team at Vitalab, huge thank you from our side as well. And if anybody has any questions or would like to make contact with Dr. Venter, I do have the email address as oncology@vitalab.com. Chris, is that correct? Can they still use that email address?
I'll rather let we share our cell phone numbers. It's so we and my partner, and again, it's just I'm happy with a WhatsApp group. So it's or just a WhatsApp. Sorry, it's we just say seen a patient. This is a history, and I always just quickly reply on it. Okay, we will get a scene tomorrow or the day after. So okay. I think I will ask if Calista will get into contact with you just to share at least 2 cell phone numbers with you as well. So
that'll be great. Thank you.
It's hopefully not too unprofessional, but yeah, I think it's just very personal and it's quick. It's always it's quicker than email. So yeah.
That's great. So what we'll do is when we load the webinar onto our YouTube channel, we will add in some descriptions of the topics that we discussed today, as well as all the information relating to contact details for Vitalab, both for Johannesburg and also for KZN. Chris, I think that's, we'll share both numbers and details for those that are living down those areas. And yeah, I think from our side in closing, I think the take-home message to those that are listening and our listeners is to please always get as much information as you can prior to starting any treatments, any cancer-related treatments, taking into account As we've mentioned, fertility, the pros and cons. Please speak to our experts. We have an amazing panel of professional doctors that are assisting our patients with certain types of queries like this. So please feel free to always get in touch with us. We'll put you in touch with the right individuals. And I think from our side, thank you again, Vitalab, for all the information. John, something in closing before we end off?
Chris, fantastic session. Thank you. Looking forward to speaking to you again soon on particularly the aspect of kids. I think that's really important and close to our hearts. Otherwise, thank you very much, everybody, for joining us. Lovely to see your faces again. And we'll see you hopefully again next week, Wednesday.
Yeah, next week, Wednesday, another webinar. So we'll share information about our topic for next week. But other than that, from our side, the Philotimo team, thank you to everybody joining us. And please keep safe. And we'll chat again soon. Take care, everybody. Thank you. Bye.
Bye.
Bye.